I'm very happy to be here today to share really exciting data with you. One of the parents on the back told me during the break, you are the one that keeps coming back to this meeting. I've been working in Duchenne for more than 20 years and doing all kinds of things from being a Duchenne doctor to helping create a synergy network in natural history and outcome measures. And, I'm now in drug development, still seeing patients. And I think that over the last few years, something became very obvious to me, and it is that when we see another drug that really works, like corticosteroids, we'll know it. And I think this is the first time that I can say I'm seeing that. John sent us all an email saying if we've been here before talking about our programs, not to go over background, disease background, or that drug background. So I cut like 15 slides from my presentation.
Nobody listened.
I listened to you. I will spend, without slides, a few minutes telling you about Akashi. And the only thing I'm going to say is that Akashi was formerly Halo Therapeutics. So our nickname is Halo. Nobody knows Akashi, but Akashi has a very purposeful name. And I ask you to go to your inserts or to the website to look at the name because it's very cool. We're also a very small company, but we've been in functioning for 4 years, and I think we have achieved an enormous amount in 4 years. I am going to be talking about the drug, the trials, the preliminary results that we have right now, and the future. So we start with the drug. And very shortly, HT-100 is an enteric-coated formulation of halofuginone. That's where Halo came from. But Akashi has other drugs in development for Duchenne, so one of the reasons of the change in name. This is a pill. It's a very, very tiny pill, and it's very potent. It's smaller than a Tic Tac, and we dose it in micrograms per kilo. So you have been looking at doses, and you take 500 milligrams of Tylenol. We dose in really micrograms because it's very potent, and it's given twice a day. Although it have a very long half-life, so it could be maybe once a day. The proposed mechanism of action of halofuginone is actually very cool, so I'm going to walk you through that. The molecular target, so where we know that the drug binds, is this enzyme. And this was the pointer?
Yeah.
I'm really bad at directions.
The arrow with the
Okay.
green button.
Oh, no. I went back, forward, this green button. Okay. So the molecular target is this protein. It's called prolyl tRNA synthetase. Very long name. What is it? It's basically an enzyme that grabs amino acids, the building blocks of proteins, and there are many of this. So this is one of those. It grabs either proline or glutamic acids, which are 2 amino acids. So it grabs them and it carries them to the machinery to form proteins. Okay, so this lives inside the cell. When you eat your food, it gets all digested, and you have your amino acid. This grabs amino acid and says, "Okay, I need to form more protein," and it just brings it into the cell. Somehow, it's a sensor. It's a sensor for nutrition. Okay, and what halofuginone does, it binds in 2 sites of this enzyme, and it is actually a novel mechanism of action because it acts in 2 sites of the enzyme. And what it does is prevent this enzyme from getting proline because it binds at the proline site. And the cell goes and thinks, oh, I'm not getting enough nutrition. And this is a sensor for nutrition. So our body has a very conserved machinery, okay, multi-pathway, very orchestrated way of reacting when you have not much nutrition. And what basically this drug does is chemically trigger this response of the organism. And it's called the amino acid response, or AAR response. So this is an integrated multi-pathway stress response to decreased nutrition. And what it does is, through these multi-pathways that are very integrated, the body says, okay, let's shut down every mechanism in the body that is consuming too much energy, and we don't really need it, and so we can conserve essential mechanisms. And that's exactly what halofuginone does. It basically, in Duchenne, says we're going to decrease all those crazy mechanisms that are taking too much energy, like wacky inflammation or wacky fibrosis. Okay? So in Duchenne, what it has been shown is that this amino acid response is really modulating abnormal processes that are very active in Duchenne. So halofuginone decreases abnormal inflammation, and this is just on the MDX, showing a significant reduction of macrophages and inflammatory cells, but also of other cells that have become really very important known inflammatory promoters in this disease, which is the Th17 cells. It also decreases abnormal fibrosis. And very interestingly, this is the most potent antifibrotic drug that it is out there. This drug is not new. There are 352 papers in PubMed, as I looked yesterday, looking at the effect of halofuginone on fibrosis. And it not only prevents fibrosis, but really reverses fibrosis. And this process is very conserved. It has been shown in models of fibrosis in vitro and in animals of every fibrotic disorder, pulmonary, cardiac, retroperitoneal fibrosis, and of course, muscle fibrosis. And then not just in Duchenne, in congenital muscular dystrophies, dysferlin muscular dystrophies, and others. So very potent antifibrotic for very conserved. And importantly, not only prevents the pathology, is not just preventing fibrosis, it really reduces fibrosis, brings it back. And what you are seeing here, this is an old MDX mouse. This mouse is 9 months old, so it's really affected, has fibrosis all over the place, and after 3 months of treatment with halofuginone, you can see, or maybe not, the red going away, which is fibrosis. And it also, because it reduces everything that is abnormal, it also helps to improve things that are essential. And that is enhancing muscle regeneration in the mouse model. So you can see the very small, muscle cell there, and when you treat with halo, it becomes really robust. So decreasing abnormal inflammation, abnormal fibrosis, and increasing muscle fiber regeneration has also some secondary benefits. So when you modulate this, you also have some other good things that have been shown with this drug, which is decreasing the cell necrosis and fibrosis in the muscle. So fibrosis, inflammation also causes fibrosis. Decreasing abnormal fibrosis, very recently, it was shown to improve and upregulate eutrophin. There is a paper that was just published that showed Duchenne muscle biopsies, and it was shown that those Duchenne biopsies, the amount of fibrosis and the amount of eutrophin in the muscle fibers was really inversely related. So the more fibrosis, the less eutrophin, the less fibrosis, the more eutrophin. And that triggered an experiment on the MDX mouse with the treatment with halofuginone, we know that reduces fibrosis. And sure enough, the reduction of fibrosis causes significant upregulation of eutrophin, which is, of course, another great effect for Duchenne. And also in a paper that is going to be published soon, it was shown that not only increases myotube fusion, but also the drug goes to the satellite cells, which are the cells that are dormant in the muscle and that go and help with muscle regeneration, and makes the satellite cells more active to help regenerate the muscle. Reducing fibrosis also helps secondarily the satellite cells to become more active, but halofuginone has a direct effect as well on these cells. So very interesting, well, we thought everything that this drug does is too good to be true, and why is it doing that? And it's doing it because it's really acting through this very conserved, multi-pathway integrated response, okay? So that's it about the drug. So now the trials. We have 3 trials going on. We call them DMD-01, DMD-02, and DMD-03. The DMD-01 is a single and multiple dose ascending dose study where we had 3 cohorts and a 4th and 5th that are going to start very soon. The HALO DMD-02 is an extension of this study, so the patients finish the DMD-01 and immediately enrolled in the DMD-02, so there's no interruption of dosing. And we just launched the DMD-03, so these patients could continue on the drug until hopefully marketing. Okay, where we are in the study. Cohort 1 patients, and there are 6 patients per cohort. Cohort 1 patient, which is the lowest dose, already finished the 12 months of dosing, and they are rolling now to the DMD-03. Our Cohort 2 patients on the 20 micrograms per kilo per day are completing the month 10 down here of the DMD-02. And our Cohort 3 patients on the highest dose so far have 4+, about 5 months on the drug on the DMD-02. And as I said, Cohort 4 and Cohort 5 are going to start enrollment in this summer, okay? We're sort of in the summer, so in the next couple of months. So who are the patients included in this trial? Patients are ambulant or non-ambulant. So 40% of our patients are non-ambulant and 60% are ambulant. Any mutation, they just have to have a confirmed DMD diagnosis, and we have to be sure there are not exceptions. 6 to 20 years of age. And they could be on steroids or they could be naive, but we do believe that they had to have a very stable baseline. And 6 months of steroids is not a stable baseline. 12 months of steroids is a stable baseline. So we request that the patient have not changed their dose of corticosteroids, the absolute dose, for at least 12 months, okay, before getting into the study. And we do not allow any changes in corticosteroid dose or any other supplements or anything else during the study. We have a lot of, this is a safety and PK study, but that's the 1B part of the study. But it's also a 2A. We put a lot of exploratory outcomes because, of course, we wanted to know. Nobody have used a very potent antifibrotic drug before that could revert the disease pathology and remodel the muscle. We needed to know if there was the younger or the older patients that will respond the best, or all of them, and which was the best outcome measure. So we have measures of muscle strength. We have measures of pulmonary function. We have measures of motor function. And we have several measures of motor function to look at maybe the same type of motor function with different measures to just look for consistency to see which one is better. So, for example, we're doing the MFM scale, is the only validated motor scales for Duchenne muscular dystrophy that comes from France. And it has 3 domains, a D1, D2, and D3, which looks at different parts of the body and also a total score. And this is a really cool motor function scale because it really expands from ambulation to non-ambulant patients. So if any of our patients loses ambulation during this study, we don't lose data. You still can look at the subdomains. We have, of course, all the time function tests, and then we have the 6-minute walk and all of that. And also we are looking at the performance of upper limb that has been mentioned several times. Okay. We have a lot of biomarkers in this study, serum biomarkers. We're doing cardiac MRI, and we're doing electroimpedance myography, which is a way of looking at muscle structure and modulation of muscle. But we are not going to be presenting that data right now. So the preliminary results. This is the population in which we're going to be presenting results. So our safety population is 19 patients. Those are all the patients that enter the study. And the results in safety I'm going to share with you has to do with these 19 patients and all the way until today. Okay. So they have received 10, 20, and 40 micrograms per kilo per day for 12, 10, and 4 months, respectively. The mean age is around 10.7, and they are all on steroids. So although we did accept steroid-naive patients, we didn't get any. So all our patients are on corticosteroids. And 60% of these patients are ambulant. The other 40 are non-ambulant. The efficacy data I'm going to show you, preliminary data, is on 10 patients of the first 2 cohorts, the lowest cohorts, the 10 and 20 micrograms, that has been dosed continuously for 8 months and 6 months, respectively. The mean age is there, all on corticosteroids, and 60% also ambulant. And then we are going to compare our efficacy data to an external control. It's a matched external control. This is from for a clinical trial that we did with the Synergy group. It was a pentoxifylline, another type of anti-inflammatory, antifibrotic drug, but much weaker. And we did that on top of corticosteroids. There was a randomized placebo-controlled study. And we have 32 patients on the placebo group that were on very stable dose of corticosteroids. That study was designed by myself, so it's a very similar design to this one. We used very similar outcome measures. The duration was 12 months, and the age was very similar. So it's a very comparable external control for our patients. And the safety results show that halofuginon continues to have a very favorable, benign safety profile, even at the highest doses. So we have a cumulative 10.5 years of dosing right now. 6 patients have been dosed for more than a year, 10 patients at least 9 months continuously. And as I said, on the highest dose group, at least almost 5 months on the highest dose. And we have 135 adverse events reported in these 19 subjects. That looks like a high number, but you have to remember that absolutely everything that happens to your kids during a clinical trial is being reported as an AE. So this includes flus, colds, and, I hurt my toe, I have a rash and a pimple, okay? So what we like to do is, of course, we ask the investigators, can you tell us if you think this is related or not related to the study drug, and what is your certainty? So when you talk about side effects, you divide them into not related, right? No, this pimple is probably not an effect of the drug. And 62% of these are not related, 25% and unlikely related. There were no AEs that were deemed probably or definitely related to the study drug. So the ones of interest is this 13% that could be possibly related, okay? So the majority of these treatment-related AEs were mild, were grade 1 or 2, and they resolved without any sequelae. Of course, we did not have any serious AEs and no death. Everybody will know about that. And the most frequent possibly related AEs are nausea, diarrhea, and headaches, which were mild, and most of them, except one patient, one time, and resolved spontaneously. Okay, so really, really very benign safety profile. So that takes me to the efficacy data, and this is preliminary data, and this is an open-label study, right? So just following the conference theme of we see a strength, I would say that we see a strength in muscle, okay? The preliminary efficacy findings shows improvement in muscle strength. We have set up a very high bar for this drug. We call no change as negative. We wanted to see improvement. This is a drug that could remodel muscle and could revert pathology. So if that was going to happen, we wanted to see improvement. And this is what we're seeing. We're seeing improvement in muscle strength is the most sensitive measure of HT-100 effect. When you look at the Cohort 1 and 2 patients, which are 10 patients, and you look at the percent increase from using themselves at their own control or with this external cohort, there is, at their own control, almost a 12% improvement in muscle strength. This muscle strength is over their baseline 18 to 22 months ago. If you remember last year, I was here saying we just came out of clinical hold. So Cohort 1 patients started the study. They received up to 3 months of dosing. They had to stop dosing because of the clinical hold. They were off drug for about 8 months, and then they restarted. And this is the data after they restarted for almost 8 months continuously. When you look at where they were almost 2 years ago to where they are right now, there is no reason for them to have any improvement of any motor and function. All our kids are over 7 years of age. So what we're seeing is an almost 12% improvement over their own baseline. When you look at our matched external steroid-treated control, those patients have usually a decrease of 10.6% over a year in this average muscle strength. So the difference between our improvement and that is about 22.3%, which was statistically significant. And of course, if you look at a steroid-naive cohort, and this is from our creatine glutamine trial, also was a randomized placebo-controlled trial, a little younger cohort, so you will expect their muscle strength to decrease a little bit less than our cohort. So this is a very conservative control, if you want. And compare it with that, we have, of course, an effect of almost 26%, which was even more significant. Okay? This increase in strength, so we have heard over the last several years, well, we don't care about muscle strength, which that's unbelievable. We do care about muscle strength. This is a disease of muscle that the first thing that causes is muscle weakness. And because of the decrease in muscle weakness, you have impaired function. So we all care about muscle strength. But the question, of course, the better question was, well, how much do you have to increase muscle strength for that to be, clinically meaningful? And I think that over the years, and Eric Hoffman mentioned the steroid trials that we did, the clinical meaningful improvement in muscle strength on the background of no steroids, of course, steroid-naive, has been established by those trials, and that is about between 24 and 30%. Okay? So the changes that we are seeing here are over corticosteroids. These changes are over 12 months. This is happening over 6 and 8 months of dosing. And we are, doing other analysis, and this line, it keeps going up. Okay? So we think that we're having an effect that is definitely going to be clinically meaningful over corticosteroids. Okay? And this includes both ambulant and non-ambulant patients. So we're not just, preventing the deterioration in the younger boys while also improving the older boys. This is what we see in the cohort 1. So now I'm separating cohort 1 and cohort 2. As you can see, these patients started, this baseline was in July of 2003, and we're looking at their, actually, this is the, this is the measure in May of 2015. It's almost 2 years. And this is the average muscle strength of that cohort with an improvement, if you just look at cohort 1, of 13.8%. And this is what the natural history will do on corticosteroids and off corticosteroids. Okay? So it's a very clear separation. And this is the cohort 2 patients. So it doubled the dose. You can see they were, their first baseline was in July. They received just 1 month of dosing before they went onto the clinical hold. You can see a significant, this is not working. But between the two black lines is when they were off drug. You can see how they deteriorated, and then you start the drug again, and you're seeing a significant improvement in muscle strength. And the last point, it's actually 2 patients of the 4. We think that likely will come a little bit lower when we have the data in the next month of the other 2 patients. But we're seeing a significant improvement the longer we're treating. What is interesting is that this increase in muscle strength that we're seeing is really consistent with clinical responses. And, 20 years seeing Duchenne patients, there are things that I know are not placebo effect. For example, we have one almost 10-year-old boy that gained a new ability that he never had, which is to hop on one foot at 10 years of age. We have an almost 10 years of age whose PI called me and said, have you ever seen a Gowers maneuver disappearing in a 10-year-old? Could he be having a late honeymoon period? Like, no, you don't see that. Okay? So, and it was when we started to hear, from parents and communities, another kid that is now playing basketball and no leg pain and things like that, that we said, well, let's go and look at the data. Okay? We were going to wait, but this was just too intriguing. So we also look at, we have all these outcomes, and what we decided to do as well, to convince ourselves if this increase in muscle strength was really significant, is to look at each patient. Because of this period of off-drug, actually what we have is almost a crossover study. So we have, an on-off and on period. So we can look at what all the outcome measures did in each individual patient. It's also important that each individual patient here becomes their own control because we have ambulant and non-ambulant patients in different stages. So what we said is, okay, we're going to look at everything for that patient, and all our patients are 7 years and older, and they are all on corticosteroids. So what does the natural history data from all the multiple groups is telling us? And none of those natural history data tell us that we should have any improvement, right? Basically, strength does not improve over time, and motor function in this population does not improve over time, neither does pulmonary function tests. So any consistent improvement that we had of a strength or function after starting the drug was considered a drug response. And I want to emphasize improvement because we did not call a positive response if it was just a stabilization, even if it was over 2 years, which we all know that will be significant, but we really, wanted to be very conservative because it is very preliminary data. And of course, we put a lot of weight to those responses associated with longer duration of treatment, like in Cohort 1. And with that, we created this Heatmap. So everything in green was a positive response, and it was a consistent improvement. In red is when we were no change or deterioration. And yellow is when there was mixed, maybe ups and downs, and we really couldn't call it one way or another. And the first thing that comes, probably to your eyes is that muscle strength was green in most of them. And there were some patients that really have improvement in almost everything, and there were significant improvements. And when you look at each one of these individual patients, you can see that the motor function really correlated with a specific strength in that area. So, for example, we have a 14-year-old non-ambulant who we are seeing clearly improvement in elbow extension and flexion strength and hand strength. And that patient has improvement in the hand function test, like the 9-hole peg test, and very clear improvements in the D3 domain of the MFM, which is also distal function. So there's a lot of internal consistency in each patient between the strength improvements and the related function in that area. So we know that we're hitting a right amount of improvement of muscle strength. 2 minutes? Almost done, because this is my summary. So in summary, this drug continues to have a very benign safety profile. The preliminary data from the lowest 2 cohorts are showing that the drug can improve muscle strength, and that the effect is probably in the clinically meaningful space, that this improvement of muscle strength does correlate with improvement in motor function, and that the drug effect is actually noticeable to parents and clinicians, right? So we don't, sometimes you don't need the data when everybody comes and tells you this is working. We're very excited about this. We have a long way to go. So we're going to enroll the other 2 cohorts. Cohort 4 is going to double in the dose of Cohort 3. Cohort 5 is going to be, a dose to be determined. We are already planning the pivotal study that is going to be started in the second quarter of next year. It's going to be an international study. We're going to use and propose muscle strength as the primary endpoint. Muscle strength has been highlighted as an appropriate endpoint for in the FDA guidelines, and also an endpoint for accelerated approval, which is great. Is relevant to the entire patient population. Is an endpoint that has been used in the clinical trials of steroids, so we can talk about what a clinically meaningful effect that would be. And also has been an approvable endpoint for other neuromuscular disorders. So we think that we're going to be well there. And last but not least, I wanted to acknowledge all our very hard-working investigators, our pharmacovigilance team that looks at all this data and keeps the dose escalation going forward. And last but not least, the DMD community. We are a fully parent-supported biotech. We have not received funding of anybody else other than Duchenne Foundations and Duchenne parents. So, we would not be here without you guys. And there is 27 foundations there, including, of course, Parent Project and MDA. So thank you very much.